Welcome, everybody. Dr. Kleberg is a meaningful use expert. He's the Chief Medical Information Officer for Stratus Health and the Clinical Director for KHA REACH and the Regional Extension Center for Minnesota and North Dakota. He has led the ONC Resource Center Meaningful Use Community of Practice, which provides support to other extension centers. Dr. Kleberg is the board chair for HIMSS, is an ex officio member of the Minnesota HIMSS Board, serves on the Minnesota Academy of Family Physicians Foundation Board, and has been a family physician and IT professional for more than 20 years. Welcome, Dr. Kleberg.
Thank you.
And one moment here, Dr. Kleberg, sorry to interrupt again. Start the recording.
The conference is now being recorded.
Thank you, Candy. Well, today we're going to be talking a bit about the Stage 3 proposed rule. And, thank you. And just to familiarize yourself with that, sorry, let me make sure I got it here. Okay, page down. So we're going to provide an overview of the proposed changes. First, Stage 3, which starts in 2017. This will also give you a framework for collecting feedback to the proposed rule. We'll be able to get some of your feedback and pass it on, but also you can provide some of your own feedback directly. And I think, as I have said in a previous talk, the people in D.C. who make these rules don't really know what it's like in our community, so they like to have feedback based upon what they have proposed within their rules. So this will also enable you to do that. As you're probably aware, we're part of the Lake Superior Quality Innovation Network. That's composed of 3 organizations, MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. And we're all collaborating together to improve healthcare for Medicare consumers, share best practices, and maximize the efficiencies. And one of our focuses is around the effective use of health information technologies. So just as a review, we've seen this before. The whole concept behind meaningful use was in the first stage, just basically put your fingers on the keyboard and begin to use it. Stage 2, let's get a little bit more advanced with it, so we'll use more decision support and more things to try and improve care. And Stage 3, which we're going to talk about today, was finally supposed to be about actually improving the outcomes of care that we provide. Also, by way of review, high-tech that was passed with the Recovery Act was really intended to just do 3 things. First, use a certified EHR in a meaningful way, provide for the exchange of health information between different providers and locations of care, and also to be able to submit quality data so that we can understand how well we're doing with our care and consequently improve it. So I'm going to have, this slide also appears again at the end, but just to give you an orientation here, the meaningful use proposed rules for Stage 3 were released in March. Now, we talked about the 2 proposed rules last time, both Stage 1 and 2 and 3, because, frankly, I believe they're quite interrelated. But today we're just going to talk about 3 by itself. And this first URL gives you a link to the Federal Register where, as I've said before, you have an HTML version of that proposed rule, which makes it very easy to search and find information. And once you find the information, if you hover over the paragraph, you'll find a little ribbon appear on the right-hand side. And if you click that ribbon, you can either copy the link or send the link or do things with it. So again, I find it very useful to, if you want to share with someone else where you've read what you've read, you can actually send them a direct link within the document to that location. So it's actually very helpful. And the second element on the screen is where you can actually submit your comments electronically. But if you go into the proposed rule document above, it'll tell you other ways you can submit it via either postal mail or PDF or filling it out online or even hand delivering it if you so choose. I didn't see carrier pigeons as one of their methods. So this is the table that appears in this particular proposed rule, where they say that in 2017, depending upon when you start your meaningful use, now that's like the 6th column from the left, you'll see that you could be at Stage 2 or 3, Or if you start late, you could be at stage 1, 2, or 3. And then you'll notice after 2018, everybody needs to be at stage 3. That's new, that everyone needs to be at stage 3. Now, if you saw this rule in isolation, and you saw this, or you read this rule in isolation and saw this table in isolation, you believe that you could be at stage 1 in 2016 or stage 1 in 2017 if you started it in 2015, 2016, or 2017. If the proposed rule for stage 1 and 2 goes through, as I mentioned last week, that's not the case. Everyone will be at stage 2 starting in 2016, regardless of when you start. So, this is the big news on this page, however, is everyone starting in 2018 is going to be at stage 2. Is going to be at stage 3. And in 2017, you have a choice of doing stage 2 or stage 3. And that's the little red X's through those numbers, or the 2 in those numbers saying the way it really will occur if the other proposed rule is passed. So, starting in 2017, that's according to this rule again, you'll have a full reporting year for all Medicare providers, even if you're in your first year. If you're Medicaid only, or if you're choosing for Medicaid in your first year, you can report for just 90 days. But if you're subject to Medicare penalties, even though you've reported 90 days for Medicaid, you still have to do a full year for Medicare. Now, that may mean that in some of those years, you may be able to get Medicaid funding earlier if you're a hospital, or if you're a professional. But again, you have to do that full year if you want to avoid the penalty under Medicare, whether or not you're taking the Medicare incentives. Another thing that they report in this proposed rule of stage 3 is that hospitals will have a calendar reporting year. So they will be reporting from January 1 through December 31st. There's no planned change in the method of attestation. You still go to a website and attest, and the reporting deadline for everyone will be the last day of February, whether it's a leap year or not. So those are the changes, that everyone's deadline will be the last day of February, and otherwise the method of attestation is the same. The penalties, or I should say the payment adjustments, to use a politically correct term, and exceptions really are unchanged. Well, there's one difference. Previously, since you could, in your first year of meaningful use, do a 90-day attestation, you could, if you attested early enough in the year as either a hospital or a professional, you could avoid the penalty in the next year, because CMS said we need 3 months in order to be able to adjust things so that we could make the payment adjustment and not have to claw back the funds. So if you attested within the first 90 days, or within the first 3 months of the attestation period, within the first 3 quarters of the attestation period, or the first 9 months of the attestation period, you would be able to avoid the penalty in the next year. But now, since you're reporting for a full year, that's no longer the case. So you would be penalized, since you have to report a full year of meaningful use in 2017. You would definitely be penalized in 2018 if you had not been a meaningful user previously, but you would avoid the penalty in 2019. So you would not avoid the penalty in the next year. That's another change. Other things, state flexibility and how they do their meaningful use is not really changed. The other thing that's very significant is that it no longer counts to hand out a paper document. So if you were counting paper in your numerators, paper disappears. The other thing, and I mentioned this last time, is in the stage 3 proposed rule, for Medicaid providers who fall below the threshold. In other words, if they are already attesting under Medicaid and they're an eligible professional, and they fall below the 30% mark for providers, or 20% for pediatricians, they would be able to attest under Medicare without switching programs. So they could attest so they wouldn't be penalized under Medicare, but they could still collect their Medicaid fundings in the following years. Again, the reason for that is that you're only allowed to switch once between Medicare and Medicaid. So if you switched to Medicare that 1 year, you would not be able to switch back. So that's a little bonus that you could actually test, not get the penalty, but still stay under the Medicaid program, if you so choose. So for this stage 3, they're proposing these new objectives, and they say this is for greater flexibility and greater simplicity, because we actually, to some extent, we do have fewer things we need to report on, and fewer elements. So here they say they have 1, 3, 6, 7 elements to report on, if I'm counting correctly. But many of these, pretty much all these have sub-elements before them, so it's not quite that simple. But these are the ones that we're going to go through: protecting patient information, e-prescribing, CDS, etc. We're going to take them one by one and go into them in greater depth this time than we did last. So the first one, the proposed objective is to protect electronic health information, or EPHI, personal health information, created or maintained by the certified EHR technology through the implementation of appropriate technical, administrative, and physical safeguards. So the measure is that you do a security risk analysis and review, and you make sure that your data is encrypted. Now, they said this last year, and they're repeating it again this year. EPHI includes all forms of electronic media, such as hard drives, floppy disks, CDs, DVDs, smart cards, other storage devices, personal digital assistants, transmission media, or portable electronic media. All those things where you're storing data need to be encrypted or secure. Once you've done that, you need to implement security updates as necessary and correct identified deficiencies. The measurement you do it each calendar year, and you attest by saying yes or no. What isn't clear, they also say you need to do it when you do a significant upgrade or change in your EHR platform. And what some have asked is that they're not really sure what would constitute a significant enough change, and in the language of the rule, that you can see that they will say as necessary, and so it isn't really that clear. Well, they say implement security updates as necessary. So the next one is e-prescribing. You must generate and transmit permissible prescriptions electronically, and hospitals must do it on their discharge medications. The measure for professionals, it's greater than 80% of all prescriptions. For stage 2, the way it stands now, it was 50%. And mind you, the numbers I'm putting up here have to do with the way stage 2 is in 2014, not the way it's proposed for stage 2 in 2015. So this is just taking it all by itself. With the way we're doing stage 2 now, with 2014 rules, the way stage 3 is proposed. So EPs go from 50% to 80%, and hospitals go 10%, which was a menu item, to a core item now, which is 25% for their discharge medications. So the denominator is the number of prescriptions written, and one of the things that they ask within this rule is whether or not that would include controlled substances, and I think that would be up to the location, but they're also wondering whether or not it should include over-the-counter medications. That's what I mean by OTCs. They're not sure whether, they're asking whether or not over-the-counter should be included in the denominator and therefore in the numerator if they're prescribed. Again, exclusions for professionals, if you write less than 100, that's the way it was before, you'd be excluded from that. And for both professionals and hospitals, if there's no pharmacy within their organization and none that accepts e-prescribing within 10 miles at the start of the reporting period. So if either of those, or both of those work for you in that second bullet, you would be excused from this particular measure. Oh, and by the way, if you have questions as we're going along here, please enter them into the chat. As I see them, I will try to answer them for you. We should have some time at the end, but ask away while you think of them, and I'll do my best to answer them as we go. So clinical decision support Implement 5 rules, basically. This is unchanged pretty much from stage 2. And you must meet both measures. So again, measure 1, 5 CDS interventions related to 4 or more clinical quality measures, or if those clinical quality measures don't fit for your practice, then there are rules that are related to high priority health conditions that would be appropriate for your scope of practice or patient population. There are no exclusions on that one. So some people are really worried about the CDS one, but if you read the rules and read the regulations, it's any sort of guidance within the EHR that will help you into making the right decision. They can be triggered order sets. They can be reminders. They can be flow sheets. They can be any number of things. And they don't have to be according to the quality measures if they don't fit for you. They can be according to high priority health conditions. So this rule is actually unchanged, and I think pretty simple and straightforward to take advantage of. And the second one, also pretty simple, that drug-drug and drug-allergy interaction is turned on for the entire reporting period. But again, if you write fewer than 100 medications in the reporting period, you'd be excused from having to turn that on. So that's for people who are not prescribers, let's say, such as someone in chiropractic medicine or something along that line. So computerized provider order entry. There are 3 measures on this particular one. Previously there was just one, and the proposed objective, and I'm going to read this out too because this has changed just slightly in terms of who can write orders, but it's still going to create confusion, I know. Use computerized provider order entry for medication, laboratory, and diagnostic imaging orders directly entered by any licensed healthcare professional, credentialed medical assistant, or a medical staff member credentialed to and performing the equivalent duties of a credentialed medical assistant, who can enter orders into the medical record per state, local, and professional guidelines. So that has always created a lot of headaches when we have to go according to state, local, and professional guidelines, who's credentialed and who's not. The credentialing organization cannot be the clinic itself. It has to be some outside organization. So that's another factor that comes into measure here. And you must meet all 3 measures. So for stage 2, you did have 3 measures, but the percentages are higher. So right now it would be 80% of all medication orders for provider order entry, stage 3, 60% of all lab orders, and 60% of all radiology orders. And they've also expanded the definition of some of the radiology orders. These all, again, must be entered by a computerized provider order entry. So they've doubled the percentages on labs and radiology and increased the percentages by 20 for med orders. Again, the denominators are all unique orders, and there are exclusions for each of these for any EP who writes less than that particular type of order. So if you write less than, let's say, 100 radiology orders, you'd be excused from the radiology order measure, but not from labs and medications. So each one of them, if you do less than 100, you'd be excused from having to report it. Patient electronic access to health information. Again, this one has 2 measures. The objective is the professional or hospital provides access to view online, download, and transmit their health information or retrieve their health information through an API within 24 hours of its availability, and I'll explain API in a moment. The second measure actually is educational materials, and interestingly, it's not mentioned in the proposed objective. And in order to pass this, you have to meet both measures. So, measure 1, either 80% of patients or their representatives, and again, or their representatives, I believe, is new for stage 3 here. Usually they said 8 patients, but now patients or their representatives are provided timely electronic access to health information within 24 hours of its availability to the provider to either view, download, or transmit, also known as BDT. The first time I saw BDT, I was thinking of this old green screen video display terminal, but I didn't know what they meant because it wasn't explained any place until later I found out it was view, download, and transmit. But VDT, their health information, that was 50% within 4 days. Now it's 80% within 24 hours. Or access by an ONC-approved application programming interface, or API. In other words, as opposed to having a website that you go to be able to download it, you could have a product on, say, your computer or your phone that would actually be able to retrieve the raw data itself and display it itself within your own application. So apparently there are going to be some ONC-approved application programming interfaces coming as well. So 80% of either of those. The denominator, again, is unique patients. For professionals, the only exclusion is that they don't have any office visits. But for everybody, if greater than 50% of their encounters are in a county with less than 50% of its housing units that have 4 megabits per second broadband at the start of the reporting period. So in other words, if you're in somewhat of an internet area or an area where people don't have good internet access, you'd be excluded from this particular element. That was, previously it was 3 megabits per second. Now they've increased it to 4 megabits for stage 3. There is a URL which I did not include here, which we will when the final rule comes out, but there is a URL which you can find out what counties actually fall within that parameter. So that's the first measure. The second measure for electronic access is greater than 35% of all unique patients are provided electronic access to patient-specific educational resources identified by certified EHR technology. Now, again, that was 10%, and it was something you could hand to them in paper. Now, it needs to be 35% of all unique patients are provided electronic access, and it needs to be electronically, so via a portal or some other methodology that they download. Now, you may question, and I may question too, does that mean that it doesn't say that they actually have to access it, but that they're provided electronic access. So that would mean that, let's say a patient doesn't have electronic access, they don't have an email address, they don't use computers, but they live in a place where there is broadband, and you provide them, there is a portal that they could access, and you do put that information on the portal. The way I read this is that you are giving them the option of the electronic access, so they're provided their access, they're just not choosing to use it. I'm going to be a little bit, I'm going to make comments here. Obviously, that's not what we want to do here. What we really want to do here is give people the information that they need. But when it comes to the provider, again, you're not going to be beholden to whether or not your patients actually use it. You're just going to need to be able to provide it. So again, it's gone from 10% to 35%, and paper no longer counts. Denominator, unique patients. Exclusions, again, EPs in their offices or they're in a internet wasteland, so to speak. Should you wish to ask, okay, I see somebody, should you wish to ask questions during the presentation, please submit them. Okay. Coordination of care through patient engagement. That's the next big objective. This one is to use communication functions of certified EHR technology to engage with patients or their authorized representatives about the patient's care. Now, there are 3 measures for this one, and again, you must attest to all 3 measures, but you really only need to meet the threshold of 2 of them. So, proposed measure number 1 is VDT API. So, for 25% of all patients or representatives, they view, download, or transmit to a third party their health information. Now, that was 5%. Now they're asking for 25%. The second option is that they access their health information through the use of an ONC-certified application programming interface. Now, what's interesting is the way you read the rule, you have to do either 25% of one or 25% of the other. if you do 12.5% of each, apparently you would not meet the threshold on this one, the way it's written. So I'm not sure if that was an error, because I would think they would like to give people the option. But again, it's 25%, and right now it's 25% of DDT or 25% of API. Again, in this, the denominator is all patients. Exclusion if you don't have any office visits, or again, if you live in a place that does not have good internet access. That's going to be a significant bump of people. So this is going to, again, depend upon people, the individual's actions. It's going to be dependent upon patients' actions. And they believe by that point in time, people will be doing it. But again, it may not be easily achievable for all providers. Proposed measure 2, this one is messaging. This one's changed as well. Now, 35% of all patients with other representatives were sent a secure message. Now, this was 5%. It was eligible professional only, and now it's both professional and hospital. But the other significant difference is actually it used to be patients sending the messages. Now it's providers are sending the messages. So even though this is 35% of an increase, it actually means that you can be sending messages to your patients the way I read it. So it may potentially be make it that much easier, and it's not dependent upon whether or not your patients use it. But again, I would suppose your patients need, in this particular one, you need to have access, because it'd be pretty hard to justify you're sending a message to somebody who doesn't have access. So again, this may require some clarification. Denominator, again, is unique patients, no office visits, or in a place where internet access is not readily available. And finally, for this patient engagement group, we have 15% of all patients' charts have patient-generated health data or data from a non-clinical setting incorporated into it. Now, this is new. So that could mean information that I read as information that I'm sending in via from my own computer, from my own personal device, or when they say a non-clinical setting, as I recall reading it, it sounded a bit like any setting that was not necessarily a hospital or a clinic. So it could be another health provider of another sort that's sending it in, and it may be very similar to health information exchange, though I'm not sure. That's the way this rule reads. Again, it's unique patients and the same exclusions. No office visits are not in a place where there's good internet access. Health information exchange. This has 3 measures, and again, you must pass 2 of them after you test all 3 measures. And actually, this one I made a mistake on our call last week. I actually said there were all 3 core measures, and I saw later that it's actually a test to 3, but you only need to pass 2. So I've corrected that. I've since corrected that, but that's not you've got the slide deck that seems to imply that all 3 need to do from last week. So this objective is to provide a summary of care record when transitioning or referring their patient to another setting of care. And remember, paper doesn't count. That you receive a summary of care record upon the first patient encounter with a new patient, or you retrieve one, and you incorporate that summary of care information from other providers into your EHR, your patient's EHR, using the functions of certified EHR technology. So one thing of note is that view-only access no longer qualifies. So some facilities, some larger facilities, would provide access to their patient portal or view-only access to their EHR, and that would mean, or that would be interpreted to mean, that they were providing access to the other facilities, and therefore they did not need to send them a summary of care documents since they had access to the EHR. That, again, no longer applies. So now they would actually have to send it and not just view-only access. The second thing that's proposed to change for Stage 3 meaningful use is that you don't have to send them all labs and all notes. One of the common complaints of the CCDA is that a person is discharged from the ICU or the hospital, the primary care provider is inundated with all these lab measures that he or she really didn't need to see, and trying to find the information that they needed in it was next to impossible. So what they're saying now is that they limit them to just clinically relevant ones, but they still need to be able to be retrieved if they are needed. So question, how accurate and up-to-date is the broadband map? That is a good question. I haven't looked at it recently, but I believe it was within the year, but I'm guessing right now. We can look that up at the end potentially and get back to you on that particular one and send you the link. So the next one, or the first one I should say, proposed measure number 1, summary of care. 50% of transitions of care and referrals, the provider creates a summary of care record and electronically exchanges summary of care record. It used to be 10%, now it's 50%. And it used to also, so that was 10% electronically, and now it's 50% electronically. And again, view only doesn't count. Denominator, the number of transitions of care and referrals, and the exclusions, again, no transfers or referrals, and poor internet access. Measure number 2, incorporate the summary of care document. 40% of available summary of cares are incorporated for referrals, transitions, or new patients. So that's the denominator is the number of encounters are referrals, transitions, or new patients. And I believe it's when the summary of care document is available. And I don't think I put it on the slide. So if you're not sent anything, obviously you can't incorporate it. So I believe that's a component of this that's omitted from this particular slide. So the denominator would be summary of encounters and referrals or new patients where summary of care is available. Exclusions, less than 100 referrals, transitions, and new patients. And again, the broadband issue. So this means you actually have to be able to incorporate this summary of care into your EHR with the medications, the labs, any notes, etc. So they're actually able to incorporate them in. And the third measure is clinical information reconciliation. So for 80% of referrals, transitions, and new patients, the provider reconciles the medications. It was 50%. Medication allergies is new, and current problem list is also new. Again, the denominator here is the number of referrals, transitions, and new patients, and exclusions, again, less than 100 of the referrals, transitions, and new patients, and in an area where there's limited internet access. As an aside, I heard from a user of one of the world's best EHR systems that their current problem list reconciliation methodology when it comes from an outside place is a bit of a nightmare in that you're forced to reconcile problems that might not even be within your specialty. So if you don't if you don't accept them, they disappear. So there may be some glitches in here on how this is executed, and to date, apparently, EHRs are not yet good at doing it. So hopefully by 2017, that will be solved. So the last group are called public health and clinical data registry reporting. So the proposed objectives for these are active engagement with a public health agency or clinical data repository to submit electronic public health data in a meaningful way using certified EHR technology, except where prohibited, in accordance with applicable law and practice. Now, this is all pretty similar to what we've seen with our previous ones of the Immunization Registry, Syndromic Surveillance, and some other registries. So it's very similar. But now they've defined active engagement as complete the registration to submit data, or you're in the testing and validation phase, or you're actually in the production phase. So there are 6 possible measures in this objective. For professionals, they need to attest to any 3 measures, 1 through 5. And eligible hospitals may attest to any 4 measures of 1 through 6. And there are 2 measures that you can actually attest to a multiple of them. So we'll get to that in a moment. So you could potentially do more than one in one of the 6 measures or one of the 5 measures. So Immunization Registry, we've seen this one before. Active engagement with public health registries to submit immunization data and receive immunization forecasts and histories from the Public Health Immunization Registry Immunization Information System. So actually talking about it as being a bit more two-way. And I also believe they've asked here if they would like predictions to come for what's due or what's not due. I know some of us have been arguing for some of the predictions to come from the Departments of Health because they've actually got that data on their website, and it would be nice if they could push that to us within our EHR so we don't have to build these complicated decision support engines within our EHRs. So again, exclusions, do not administer immunizations, and no capable registry. Number 2, syndromic surveillance. Again, active engagement with a public health agency for a non-urgent care ambulatory setting for EPs or an emergency or urgent care department from an eligible hospital. And for this, there's an exclusion if you don't treat or diagnose any disease or condition associated with the syndromic surveillance system. So again, active engagement, yes or no. Case reporting. Active engagement with a public health agency to submit case reporting of reportable conditions. You don't treat them or the exclusions, and no capable registries. Again, yes or no. Public health registry. Active engagement with a public health agency to submit data to public health registries. This one you can count more than once. Again, if you don't have any reportable cases or a capable agency, you can use that as an exclusion. Now recall, starting in 2014, and it's still true now, an exclusion does not count as one of the 3 that you or 4 that you need to report. The only way you can report less than 3 or less than 4 is if you can exclude all your other options, and you have to be able to demonstrate you can't do any of your other options. So if you don't have any agency that is able to accept any of those things, then you would have an exclusion to be able to report these. Clinical data registry, active engagement. Again, and this one you can count more than once. Again, similar exclusion that does not treat reportable cases and no capable registry. And finally, the proposed measure number 5 for hospitals only is active engagement with a public health agency to submit lab results. Exclusion does not perform reportable tests, and no capable agency or the agency is not ready. Does the public health reporting need to be reported from the same EHR or multiple EHRs submitting separately? Now, if you're an eligible professional, it needs to come from your one EHR that you're using, which can be a combination of products. And if you're a hospital, again, you'd be submitting from, I get it too, if you're a professional working in multiple places, I imagine it would be coming from multiple EHRs if you're in multiple sites. I don't know that that's been specified, to be quite honest. But I don't know, for example, if you're working at one site where you have reportable cases and another site where you don't, it would seem to me that that one site would be where you would report. If you're at multiple sites with multiple cases, but you've only been able to make the arrangement with one of the sites that you're working at, I mean, that is a good question. I think that may need to be asked in order to be answered, because I'm really only guessing. That's not been specified in the rule. Good question. So back to measure 5, the lab results. That's really unchanged from previously. So again, we heard about this last time, and these are the topped-out measures that we mentioned here. It's just a list, a summary list. We'll go into them in a little bit more detail in a minute. But it's just a summary list of all the measures that have, quote, either been topped out or felt to be redundant because they're asked in another way in another place. So if we look for the changes from 2014 Stage 2 to Stage 3, here are the comparisons of some of the changes. Not much changes except for the formulary has actually gone from menu to core for the hospital, 10 to 25%. CPOE for medications, labs, and radiology have increased, and patient education has also increased. But again, what it doesn't show on this screen is that paper doesn't count. So it has to all be electronic for the patient education. On this, the changes from, again, Stage 2, 2014 to Stage 3, we'll see that the access to view down transmit or API from Stage 3 has gone from 50% to 80%. And then we see that to the actually view, download, and transmit, or patients using an application programming interface, or secure messages, or incorporating patient or other programming data have all gone up and are 2 out of 3. So, for example, patient using API is new. That's part of the view, download, transmit, or API. Then you have the secure messages. They've gone to 35%. It's one of the 3 that you can order on, and again, that messages from the provider to the patient. And incorporate patient or other provider data coming from another site is 15%. So again, that one is new. Summary of care. Incorporate electronic summary and clinical information reconciliation. Again, you report on all those 3, but just need to do 2 of them. Electronic summary of care has gone from 10% to 50%, and the incorporated electronic summary and the clinical information are both new, and they're at 40% and 80%. Again, now, these are proposed, so we'll see what actually turns out in the final rule. And then we see the Immunization Registry, Syndromic Surveillance, Case Reporting, Public Health, etc., all appearing. There's a little bit more options there than there were previously. One concern of our Department of Public Health is that they're concerned that some people may opt not to do the Immunization Registry if they're able to, because it's no longer required like it was. You could choose some of the other ones and actually fulfill your public health reporting without doing immunizations. So if we look at the ones here that are no longer included, okay, the summary of care method that's done via paper, that used to have to be 50% of them. Again, paper is no longer required, but we do have to send it electronically. Electronic summary of care with a different EHR system, that's not included because I guess they're assuming since it's so broad right now, you would be giving it to someone with a different EHR platform. Medical reconciliation, cancer registry, specialized registries, all are the new, well, I think that the medication reconciliation is from clinical reconciliation. Cancer registry and specialized registries is an error there. That's actually part of the new registry elements here. That's not ClinReg. I need to correct that. Demographics, vital signs, and smoking, which used to be core elements, now are in the electronic access to information. And one of the challenges that I really have in understanding this is how are they going to know that that information is in there unless there's some trigger to check for it. Again, it also can be in the summary of care document, but the summary of care document, if there are no referrals, the document may not be created. So how are they going to measure whether or not it's actually done and in there is a mystery to me. Family history, which was a menu item, which they say was topped out, that doesn't appear any place in particular. Advanced directives, which was a menu item, doesn't appear any place in particular in the Stage 3 rules, nor does using an EMR in the hospital. that also doesn't appear anywhere in the Stage 3 rules. Provider notes, which were a menu item, which apparently just required one provider note in a patient record, is now in the summary of care document. Imaging results, we're not sure that's not specified that needs to be viewable within the EHR anymore. Incorporating lab results, clinical summaries, or electronic access, patient lists, patient reminders, and provide lab results are two of them are no longer patient lists and patient reminders. Again, they're not appearing any place in particular, and provide lab results again are now in electronic access. So again, quality measure reporting for 2017 is a full year, except for those who are Medicaid only. You may electronically report 2017 electronic quality measures or attest to the 2016 electronic quality measures. And obviously these haven't been defined yet. And they're also asking vendors to certify to all the measures, potentially gradually over time, so the professionals can actually have measures that they can use that are appropriate to their scope of practice. For certified EHR technology, you can use 2014 or 2015 certified EHR technology for in any combination for meaningful use stages 1 and 2. But you can only use 2015 certified EHR technology for meaningful use stage 3. That would be in 2017 or in 2018. For reporting electronic clinical quality measures, if your EHR is 2014 certified, but you actually have incorporated 2015 certified EHR technology for the quality measures, you can report on 2017 quality measures. All seems silly, but it's in the proposed rule. If you have 2015 certified EHR technology, but your quality measures are on 2014's certification, you would report to the 2017, actually, you report to the 2016 measures. It's incorrect there. I need another correction. If you were going to do it electronically, you would report it with the latest version, and you can, using attestation, you can use any version, 2014 or 2015 in 2017. Obviously, in 2018, you're going to need to use 2015 certified EHR technology. Just in that 2017 year, you've got a choice of doing either. So all the quality measure information that's not really part of this proposed rule, that's all stuff that will be coming later on in separate rulemaking. So again, to review, this is a place in the Federal Register where you can find the proposed rule. The comments are due Friday, 5 o'clock Eastern Time, 4 o'clock Central Time today. So if you have some comments or questions about these things, be sure to ask them so that they answer them in their final rule, which again we probably won't expect to see until late in the summer. And with that, again, what I want to remind you is that the Lake Superior Quality Improvement Network does have consultative services to help you with meaningful use of Stage 3 and Stage 2. They provide education, technical assistance. We have learning and action networks. You can actually learn from each other and work together as groups. And all this work is free of charge for you. And finally, here are the contacts at each of the from each of the particular states that can help you with your work. Finally, yes, the comments today. Comments are due May 29th, this Friday, not today, at 5 p.m. Eastern, 4 p.m. Central. If I said today, I goofed. I'm sorry. So with that, I will end and see if there are any questions. It's been an extremely quiet bunch in the chat here today. I expected to at least see a couple, except for that one that I really couldn't answer. What's the date of the map?
6/30/14.
Oh, so we just looked at the data map, and it's apparently been last updated 6/30/2014, so it's about a year old. So that doesn't mean it will be updated on 6/30/2015, but at least we know it's not ancient. And again, when it comes to measuring that data availability, it depends upon the start of your EHR reporting period. So if all of a sudden Google Broadband shows up in your neighborhood in the middle of the reporting period, you don't have to worry that all of a sudden now you fall within the ability to access broadband. There's a question: how can I access the slide decks for each of these presentations?
And I can go ahead and field that one, Paul. The slide decks and recordings for the presentations will be available on the LSQIN website at lsqin.org as soon as they are prepared and transcripts are made. So I would expect to see those up on the website within a week and a half here.
And the previous one where I just noted a date error since it was last posted, we can update that, and will people know that it's been updated on the website?
Yep, we sure can, Paul. There's been no slide deck currently posted, so anything that we upload will be current.
Okay, good.
And I suppose while we're waiting for anyone else to submit last-minute questions into the chat box, we'll plug our next and series finale of this webinar series. It's occurring next Monday from 12 to 1 p.m. Central Time. So you can go ahead and join that webinar by going to qualitynet.webex.com and join me like you did today.
And that webinar will be on the proposed changes to Stage 1 and Stage 2, which actually has much more immediate implications for everybody, even in this very year. So, for example, if you're trying to attest right now, and you'll find that the attestation website is down because of what they said with the proposed rule, that people will not be able to attest until January of 2016. So tune in next week to find out more about the proposed changes for 1 and 2, and the comment period for that ends on, I think it's June 14th or June 15th, one or the other. So again, a little aside on this particular element, and I think I may have mentioned this last time, one of the philosophies around Stage 3 was around improving quality. And one of my frustrations is that it still seems right now that we're measuring provider clicks and providers sending electronic data, but we're not measuring, is that information that we're sending to patients useful to patients? We're collecting their preferred language, but we're not measuring how often they're getting it in their preferred language. We're not measuring, are patients satisfied with the information that they're getting? Do they find it helpful? I mean, are they feel like they're better able to manage their care as a result of it? And are they getting it in the format that they like? Are they getting it in paper? Right now, what we're measuring is if they're getting it electronically. So I understand what they're trying to do here, but personally I have some concerns about Stage 3, and we'll see what actually comes to fruition when the final rule comes out, probably sometime, as I said, late this summer, early this fall. So I suppose if we've got no other questions, we can give everybody back 3 or 4 minutes. We'll give you just a couple, maybe another minute, and we'll see if there are any more questions for anyone who may be typing slowly, like me, or like I do.
And we'll be able to expect another webinar from you when we have final rule, I'm assuming.
Yeah.
Yeah.
So I'm not retired by then.
All right.
Well, thank you all very much. I hope this was valuable. Please.
We'll see you all on our webinar next Monday, June 1st, from 12 to 1 p.m. Central Time.
Is there evaluation at the end?
There will be an evaluation after you leave today's WebEx, and we appreciate your feedback on it. Thanks much, all.
Thanks. Bye-bye.